welcome. I'm Elizabeth Edgerly. I'm the Executive Director for the Alzheimer's Association up here in Northern California. And we have a wonderful lineup of presenters here today. As you can see on my screen, we have Dr. David Reuben, Chief of Geriatric Medicine at UCLA. Thank you, Dr. Reuben. We have Molly Davies, who is presenting in partnership with Dr. Reuben about her work at Wise and Healthy Aging. We have Anastasia Dodson, the Deputy Director of DHCS and a key leader in the state of California around this initiative, and also responsible for bringing this webinar to you today. And then there's me, your moderator, Elizabeth Edgerly. So as we dive into the webinar, I wanted to give you some of the housekeeping information. We are going to save 10 to 15 minutes at the end of the session. Please put in the Q&A in writing what your questions are, and then we will address those. We may be able to answer some in real time, or we'll address them at the end. If we can't get to all of them, we will try to capture your questions and then gather those answers for you afterwards. If you're here and you are looking for continuing education, you're going to get an email within 48 hours, and you'll need to claim that credit. So please be on the lookout for that. We have the recording taking place, and so you'll also be getting an email with that. And you can access these webinar slides and the recording from our Dementia Care Aware website and YouTube channel. So thank you so much for being here. Our learning objectives are really understanding the guide model. And at the end of this, hopefully you'll have a better sense of what does it take, what does it mean to even participate in this project. And hopefully you'll be able to list 2 examples of a successful partnership in California using the guide model, and identify 2 resources at the end so that if you choose to apply, you know what resources are out there for you. Before I turn this over to Anastasia, I actually wanted to share with you a little bit about the importance of this kind of work for families.
I think a navigator would have changed the whole trajectory on a lot of things, on how we had family and friends exposed to the disease, on how I felt. But I think looking at the future now and what that looks like, you know, I remember sitting there and saying, it felt like it was just us, and we were going to different medical systems and seeing different doctors, and Corey kept saying, "Guy, isn't there just one person that we can have?" We got to one place and we thought within that system there would be somewhat of a navigator, but really it was more of a scheduler. And what I needed was to know that my security was getting the help that she needed. There are many times through this process, people will say, "Tony, what do you need? Take care of her. Tony, what can I do for you? Take care of her. Because she's taking care of me, you take care of her, and I'll be just fine." When I show up and I see how angry she is, or I see she's crying at night because we're not getting what we need to get, that's hard on me. So then my symptoms present even more, or I'll have a worse day, or I won't be able to function correctly. So having that navigator seems almost like a third base coach or a representative that will advocate for the team, for all of us and for both of us, and give us the support that we need, have the connections that are there, and get us scheduled.
Dr. Edgerly, we really appreciate the opportunity for the partnership that you can see on this call with the Alzheimer's Association, with UCLA, with Dementia Care Aware, and the ADC program. We know that for the, and really what we, overarching CMS, the Medicare program, that is looking for applications among providers, among all of you, for their guide program. So we know, obviously, there's a tremendous need. There's a number of people in California that have Alzheimer's or related dementias, and among those, a disproportionate number are also eligible for Medi-Cal. We call them dually eligible. And so at the Department of Healthcare Services, our main program that we administer is Medi-Cal. And again, there's people who are dually eligible for Medicare and Medi-Cal. There's about 1.7 million of folks in both programs in California, and they have a much higher prevalence of Alzheimer's and dementia than people who have just Medicare. And so that's part of the reason why we take a great interest in this policy area. Also, we have a broader mission, actually, with a small office that we have at DHCS looking at Medicare issues overall. So we're so pleased when CMS Medicare announced this guide model opportunity for providers that are serving patients that are in original Medicare. And we have been discussing this with CMS and really pleased to have this webinar here today. And I know it's going to be recorded, and we encourage you to talk to your partners. There's a short window on the application. We're going to say the same thing several times here of there's a due date for the application. We really encourage you all to apply, and we hope that we get applications in California from a variety of geographic, race and ethnicity, language providers, because we are a very diverse state in California. We have health equity issues that we want to address and improve on, and those apply very much so in the treatment and care for individuals with Alzheimer's disease and caregivers as well. So having that diversity in providers to treat the diversity in patients is important as well. So anyway, with that, I'll turn it back, but thank you very much for joining, and please tell your colleagues about this.
Awesome. Thank you so much, Anastasia. We're really excited about this, and I do hope that people apply. And now it's my pleasure to turn it over to Dr. David Reuben.
Dementia is the worst fear of aging, and really for good reason. And these are pretty recent data. They're, I think, the best, that about 6.5 million Americans have Alzheimer's disease. And that doesn't include other forms of dementia. By 2025, it'll be 7.2 million. And this is a disease of aging. So as you're 65 to 70 to 69, maybe 3.5%. But by the age of 90, it goes up to about 35%. So in 2036, the first of the very first of the baby boomers will reach 90 years old. And so this is going to be truly an epidemic. Next slide, please. Well, if that's not bad enough, there's a huge dementia quality problem. And these have been a number of studies that show that 38 to 44% of quality indicators, as measured by the ACOVE, or Assessing Quality of Vulnerable Elders, indicators are met. So the quality of care that are established best policies or minimum standards are not met. And these include cognitive evaluation. If there's a positive screen, only a quarter of people get that. Checking their medication to see if they're medication contributors to cognitive impairment. Caregiver support, providing caregiver support, less than a third of people receive this. Monitoring for behavioral or psychological symptoms, fewer than half. And moreover, there are poor linkages to community-based resources that provide these services very well. Next slide, please. So what are we dealing with? We're dealing with some big consequences, particularly financial and utilization. Almost $350 billion in healthcare, 3 times the number of hospital stays, higher provider, nursing home, and home health and drug costs, but caregiver burden. Over 11 million caregivers providing 17 billion hours worth of care. It's huge numbers. Cost of care for persons with and without dementia. These are pretty recent data. And you'll see both to Medicare, Medicaid, out-of-pocket, and total costs about 3 times as much if you have dementia versus those who are the same age who don't. Next slide. So in response to this, there's a concept called comprehensive dementia care. And it focuses on patient and caregiver. And this is important because a lot of the early efforts in dementia were focused only on caregiver support, but comprehensive dementia care includes both. It includes continuous monitoring and assessment, ongoing care plans, psychosocial interventions aimed at the person who's living with dementia and their caregivers, self-management, medication management, treatment of related conditions, and coordination of care. So this is the kind of framework, and as we get into the guide model, you'll see how it's operationalized. Next slide. There are 6 programs that are in operation right now that have good evidence for providing comprehensive dementia care. The Benjamin Rose Institute out of Cleveland, their care consultation model, which is based at community-based organizations. Care Ecosystem, which is based out of UCSF and provides telephone management as care navigators at community-based organizations or through health system. Ashkenazi Healthy Aging Brain Center, which includes in-home visits by staff, unlicensed staff, but they're backed up by healthcare workers. Integrated Memory Care Program, which is a in-home support service that's backed up by nurses. Oh, excuse me, I'm sorry, that's Mind at Home. Integrated Memory Care is a little different. It is a program based out of Emory, and it is nurse practitioners providing primary care. So they provide not only the dementia care, but all the care for these patients. And finally, the UCLA Alzheimer's and Dementia Care Program. I'm going to say a little bit more about that. Next slide. These programs differ. They differ in the staffing, they differ in base of operations, some are based in the community, some are based in health systems. And the good thing about Guide, it can accommodate both of those. Scope of services that are provided, some provide medication management, some don't, for example, how intense they are, the cost of running the program, how effective or pragmatic they are, the potential return on investment to these, how profitable are these organizations or these models, and the level of evidence. Next slide, please. And we're not going to have time to go through all this, but you will have a copy of these slides. And these are actually quite recent comparisons of model by model. And you see how they differ, who the personnel are, whether they have order writing capabilities, whether they do medication management, and the kind of benefits they have. So in selecting a guide model, and all of these with some appropriate modifications would be eligible for guide. And I have some very good news today, some very good news that yesterday, the John A. Hartford Foundation approved a grant to provide some help to all these models to help them disseminate their models in preparation for guide. So that's going to kick off in early January. But if anybody has interest in this, you can send a message to me, and I will be glad to put you in touch with the people. Next slide, please. So the Alzheimer's and Dementia Care Program. Go ahead. Next slide. Okay. Recognizes that the care of dementia is a long journey. Next slide. And it approaches the person living with dementia and the caregiver as a dyad. Both need support. And if you're only treating one, you're not getting the job done. You have to treat both. The ADC program uses a co-management model with an advanced practice provider who is usually a nurse practitioner, but sometimes is a physician assistant or could be a nurse clinical specialist, who do not assume primary care of the person living with dementia, but work with primary care providers. It provides comprehensive dementia care that is based in the healthcare system, but reaches out into the community. Next slide, please. And the mission of the ADC is to partner with families, physicians, and community-based organizations to maximize person living with dementia function, independence, and dignity, while minimizing caregiver strain and burnout. And that's what the program has been doing for the past 12 years. It is a multidisciplinary care team model. We'll get into that in just a moment. And it works with the primary care and specialty physicians We care for patients by conducting in-person needs assessments, developing and implementing individualized dementia care plans, monitoring response and revising as needed, providing 24 hours a day, 365-day-year access. And this is a required component of the guide model. Partners with community-based organizations to provide direct services, including adult daycare and caregiver training. They have been terrific partners. Next slide. The dementia care specialist, who will be the dementia care navigator for the guide model, as I said, is a APP, nurse practitioner, PA, or clinical nurse specialist, based in the hospital or based in the healthcare system, and follows approximately 250 patients, and is supported by a non-licensed dementia care assistant, generally, although some places where we've implemented this have to use a registered nurse or social worker, and ironically enough, we have a pharmacist who is preferring this to providing pharmacy work. They reach out to lower acuity people with dementia and offer resources. They identify dyads in crisis, people who their status is changing, and they refer them to the dementia care specialist. And this allows the dementia care specialist to work at the top of her license and have a higher patient load. I said the top of her license. The entire UCLA Alzheimer's Dementia Care Program is all women. Yeah. Next slide, please. And these are our community-based organizations and the services they provide: adult daycare, programs for brain health for people with earlier dementia, education, counseling and peer support, case management. Things like legal and financial counseling occasionally is incredibly important. Support groups, and these are funded by a voucher system. Thus far, it's been pretty much all philanthropy, although Dementia Care Aware will provide some of this. And so the dementia care specialists, these advanced practice providers, will determine the need for an individual patient needing adult day services or individual counseling, and provide a voucher. It's an electronic voucher that will, the patient can redeem, caregivers can redeem. And then when the patient goes and receives these services, the community-based organization will invoice us. And what I would like to do is introduce Molly Davis, who is the lead at Wise and Healthy Aging, who's been one of our partners since the get-go. So Molly, take it over.
Thank you, Dr. Reuben. So we have been part of this partnership, gosh, I think since the very beginning, and it's had a variety of different services that we provided over the years through this partnership and voucher program. But I'll tell you a little bit about Wise and Healthy Aging, so you have a sense of the type of partner that we are. We're a community-based nonprofit that provides services to older adults and their caregivers throughout Los Angeles and San Bernardino counties. And we have the programs that are that partner most directly with the UCLA Alzheimer's and Dementia Care Program are our case management program and our adult day center. So our adult day center is a social model program, and we have an early memory loss program, which we call Wise Minds. We have our standard group, which is our larger group of folks. And then we also have our Somos Amigos program, which is a Spanish language adult day service center. So it's a specific pullout group for folks who are from our Latinx community and are more comfortable in Spanish or only speak Spanish. So this partnership has been tremendously important for Wise and Healthy Aging. it has not only created a referral source for the organization, but it creates a partnership. So a referral is, handing something off, handing someone over, but this creates a partnership where there's communication both ways when there's changes in condition. It also creates a way for, since the vouchers are short-term, it gives us an opportunity to find other ways to fund services for our clients. So the vouchers provide that bridge while we're looking for what other ways to fund services for them, but also getting to know them and getting a sense of what their needs are. We provide, so the vouchers provide for days at the adult day, and then also caregiver support groups. So we have in-person and virtual support groups because we support caregivers who are long-distance caregivers and local caregivers. We're really trying to work with both the caregiver and the client. In our case management department, we always try and connect our clients who are coming to our adult day with case management. And one of the other aspects that is vouchered by this program is to help individuals sign up for benefits. So we help with benefits enrollment. We'll sign clients up for Medi-Cal, or we'll sign clients up for in-home supportive services, and then help them hire a caregiver and work through that process. So often it's that benefits that is the urgent need, and that's sort of the gateway, right? So we've done something for them, and then they realize that, maybe they'll take us up on all these other array of services that we can provide. But I just really want to highlight that, this is a person-centered model. We do assessments with folks to figure out what kinds of services they may benefit from, either in-house that we have, or other services we can help apply for them outside of our agency. And again, it's it's not just a referral, it's a partnership to help wrap around clients and help to keep them living in the community as long as possible. And it's been a successful partnership.
Thank you so much. And I just have to reiterate is that we certainly couldn't have done it without you. And one of the things that I've been arguing for with CMMI, which is the Center for Medicare and Medicaid Innovation, is that we need to get money into community-based organizations. There are many services that they can provide far less expensive than healthcare systems, and they do it better. So we are grateful, and the guide model really does recognize this. We'll talk more about that in a few moments. Next slide, please. So does this system work? I mean, is there any benefit to this? We were very fortunate in being a recipient of the original CMMI Health Care Innovation Challenge Award back in 2012 that started the UCLA Alzheimer's and Dementia Care Program. And as part of that, we had a number of evaluations. It was a 3-year program. And first thing we found out is that the quality of care, once again by nationally established ACOVE quality indicators, was much higher than you would get from community-based physicians, or even if you added a nurse practitioner with more general roles. But 92% of quality indicators were met. Next slide. And then there were benefits for persons living with dementia and caregivers. Actually, cognition and functional status were worse after 1 year. And what that tells us, and we have to recognize our limitations, is that good quality caregiving does not cure dementia. On the other hand, it does provide benefits. These patients had fewer behavioral systems, the agitation, the irritability, the aggression that lands people into nursing homes. And moreover, their caregivers less distress because of behavioral symptoms, less caregiver strain, and fewer symptoms of depression. So everybody benefits. And I think something that was very helpful in trying to get this through Medicare was the utilization and costs. And these weren't our analysis, these were actually Medicare's analysis, were that emergency department visits were reduced by 20%, which was statistically significant. Hospital days were reduced by 26%, again, statistically significant. And that was because we were able to get people out of the hospitals quicker because they had somebody to pick up afterwards. Fewer long-term nursing home placements by 40%, and increased hospice use in the last 6 months. Overall, there were $2,400 per year per participant savings to Medicare. And this kind of set the stage saying that this would not be a bad idea. This might be a very good idea. Next slide, please. So after years of trying to go from this demonstration project to policy, last summer at the National Alzheimer's Planning Act Advisory Committee, the head of Medicare announced that there's going to be a new voluntary guide model that aims to improve the quality of life for people living with dementia, reduce burden and strain on unpaid caregivers of people who are living with dementia, and prevent or delay long-term nursing home care. This was a webinar. It was open to public, and I watched it. I remember it very vividly. And as I was watching it, tears were rolling down my face. And it was not for me or anything that we had done. It's for the potential benefit for people with Alzheimer's throughout the country. This is the first time, and they acknowledge this, is that Medicare has ever done anything for caregivers. So this is really a monumental step. Next slide, please. So the guide model has 5 components. It identifies a standardized approach to care delivery. We'll talk about that in a moment. Providing an alternative payment model. And this is big. So this is something that Medicare has not provided, and that's why it's going through the Innovation Center. It's a monthly per beneficiary payment to support team-based collaborative care. So as long as you're involved in the guide program, your guide participant will receive money. It addresses unpaid caregiver needs, including 24-hour access, training, support, connections to community-based organizations. Respite service. This is huge. These are temporary services provided to a beneficiary, and an in-home option is necessary. It's a required component, but it also can be in an adult daycare center or at a nursing facility that can provide 24-hour care. The important thing about this respite care is that it is for all guide beneficiaries. These are people who have dementia, who have Medicare. And it's up to 20 if they have moderate or severe dementia. And it is not means tested. And it's $2,500 per year. So we can talk about that more in the Q&A, but this is huge. And then screening for health-related social needs and helping people navigate mostly through CBOs to address. Next slide, please. All right, guide model. So the patient, i.e. the beneficiary eligibility, have to have a diagnosis. This is not a program for people with mild cognitive impairment. And a physician has to certify the diagnosis. Medicare has to be their primary payer, and they have to be enrolled in Part A and Part B, but not Medicare Advantage, not SNPs, special need plans, or PACE program. Not enrolled in hospice, and not residing in a long-term nursing home care. So they have to be community-based and participating in fee-for-service Medicare, basically. Next slide, please. Medicare is basing this on patient navigators, which they've used in other systems, such as the Chronic Kidney Disease Program, who are personnel whose role is to partner with patients to help them identify their needs and goals and overcome barriers. And there are going to be dementia care navigators, so we can talk more about that in a few moments. Next slide. There are 9 domains, and we'll go through those in just a moment, that are required. There must be an interdisciplinary care team. There must be a standardized training for care navigators. There needs to be a person-centered care plan, care coordination, and caregiver services. These have to be included in the delivery. Next slide, please. So ADC and GUIDE, I'm going to give you an example because I like to think, I'm not entirely sure, but I like to think that some of GUIDE was based on some of the components that we were able to develop in ADC. But the advanced practice provider in our case is a nurse practitioner, and this will be our dementia care specialist, dementia care navigator, nurse practitioner, PA, or clinical nurse specialist, healthcare system-based approach, dementia care co-management, with each dementia care specialist following 250 patients. Next slide, please. Training is required. So we have developed and worked with GAPNA, which is the Gerontological Advanced Practice Nurse Association, 22 online modules, and there has to be a 10-hour component didactic training, and this would satisfy that. And then there also has to be live intensive program, and that has to be at least 10 hours. Next slide, please. These are the care delivery activities, comprehensive assessment. That's done, at least in the ADC program, by in-person initial assessments. GUIDE also allows them to be done remotely. There does have to be, however, for people with moderate or severe dementia, an in-person visit conducted within 60 days of enrollment. There has to be a care plan, and that care plan needs to address all assessment domains. 24/7 access. The way we have done it at UCLA is the Geriatrics practice covers the ADC program, but other places have used palliative care practices or other practices to cover. Ongoing support and management. And here the dementia care navigator is the main point of contact. Care coordination and transitional care management, sharing the care plan and keeping others involved. Next slide, please. Referral and coordination. And here the community-based organizations, at least from our perspective, are incredibly valuable because they can augment the services that a healthcare system could provide. Medication management reconciliation. Here, the advanced practice providers all have prescribing authorities, so they can get rid of bad medicines and prescribe more appropriate medicines. Caregiver education and support. This is done a number of different ways: skill training, support groups, both through the CBOs and through actually UCLA provides support groups. And we have caregiver support videos. We have 18 of those. Respite care. So this respite care, there has to be an in-home capability, and that's generally contracted with a home care agency, not a home health agency, but it could be. But that has to be a caregiver who can come into the house. And then for the other options, such as adult day health, that will largely be done through the CBOs. Next slide, please. Okay. So we've talked about most of this, the care team requirement. They have to have a clinician with dementia proficiency, and that's generally a physician medical director. Care navigator training, we spoke about that. And then there are performance measures. And with performance measures, you can increase payment up to 10% or take a penalty of 3.5%. And those performance indicators are high-risk medication management, quality of life established by of the person living with dementia, reduced caregiver burden, reduced total per capita cost, and reduced entry into long-term nursing homes. So all of these will either give you a boost or a small penalty. Next slide. So some cons and pros of using Alzheimer's and dementia care as a model for GUIDE. It tends to be more expensive. We utilize higher level dementia care navigators, advanced practice providers rather than a community health worker. The team is actually larger than the required minimum because they're working in healthcare system requires space and support for the clinicians. On the other hand, there's a number of pros. It covers everything the GUIDE requires. It's almost like plug and play. There's strong evidence that will achieve Medicare's goal for GUIDE. And the caregivers enjoy their work. They find it incredibly gratifying to do this. It helps primary care providers and physicians a lot. And it's tried and true. It works. We've had over 4,000 people at UCLA who've received this care, another 2,500 or so around the country. Next slide, please. All right, so payment. It's per beneficiary per month, and these are determined by 5 tiers based on whether people have a caregiver or not, and the severity of their dementia. As I mentioned, performance and also health equity are adjusters for the payment. Respite care up to $2,500 per year. And there is also an infrastructure payment for safety net providers. It's a one-time lump sum of $75,000 for program development. We can talk about more of that in the questions and answers. Next slide, please. So getting in. To be eligible to be a GUIDE participant, and a GUIDE participant is not the patient, the GUIDE participant is the health system. You have to be a Medicare Part B provider. Okay, and we'll talk about that in a few minutes, how to get in. You have to have an interdisciplinary care team, including the care navigator and the clinician with dementia proficiency. And there are 2 tracks. The first are established program if an organization is already providing this care in 6 of the 9 domains for at least 12 months prior to January 30th. And a new program is if you haven't gotten this up and running, you would still be awarded to become a GUIDE participant, but you wouldn't start implementing until July 2025. There's a 1-year implementation ramp up. Next slide, please. All right, so how to do this? This is directly from the RFA, which is actually very good. One way, let's say you were a large healthcare organization and you had a lot of resources, you might do it all yourself. So there's no partnering organization. Let's say it's a huge medical group and it has geriatricians and nurse practitioners and neurologists and care navigators. You can do it all by yourself, but you have to have a Medicare Part B provider and a tax ID number. The second example is, next slide. Okay, so here you have a participant who, for example, it was a geriatric practice, but they participate in partnership with a partner organization. Here they talk about it being a home health agency or an occupational therapy practice. But here, the guide participant does the billing. They bill all the services, and then they set up contracts with the partnering organizations. And the partners organizations can't bill Medicare for these services themselves. Next slide, please. The third way is a home health agency. Let's say they're interested in doing this, but they don't have a Part B practice. They could apply to become a Part B practice and have, or they could partner with an existing Part B practice. Next slide, please. And the fourth way is that a CBO, which is a partner organization, would partner with a primary care practice, but the primary care practice would have to be the guide participant. And then services are billed under the primary care practice and contracted to the community-based organization. So there are a number of ways of doing this, but the key thing is that the money will have to flow to the Part B provider. Next slide, please. It is an 8-year model. It is starting, it was announced last summer, obviously. The requests for applications are due on January 30th. That's an important date. And this is important because as planned at this point, there's going to be no second chance. It'll be a one-time application. So if you don't get in the first time, the way they're planning it now, there's not another opportunity. The established programs will start their care and start getting paid on July 1st. The new programs will have a 1-year implementation period from July 1st, 2024 to July 21st, 2025. Next slide, please. So how we can help you. For any site that is contemplating using the ADC model, we are setting up weekly office hours. We set up our first one was this week, and we'd be glad to answer your questions about adapting ADC to your institution. There are a number of institutions that have been Dementia Care Aware participants who have signed letters of agreement to us. And for those folks, and if you're interested in signing a letter of agreement, we will have one-on-one meetings with you. We will provide specific language about the Alzheimer's and Dementia Care Program that you can insert in your guide application, so you don't have to recreate it. And we'd also be glad to review draft elements of the application. So I will admit that we are working on our own application. That's how I spent the last hour. But we also find it very important in our mission to try to help as many sites become guide participants as possible, because the real beneficiary will be the people living with dementia and their caregivers.
Thank you, David, for all the work that you put into that. I know it was a tremendous effort to do that. And was there one question that you wanted to start with, Anastasia, based on what was in the chat and the Q&A?
You know, I've been putting the answers about, you know, guide applicants must be Part B providers, Medicare Part B providers, and answering general questions. I think it would be wonderful if some of the more technical questions, if David's able to answer, like, can we still bill normal E&M codes while in the guide program?
Yes, this is new money. There are a few codes that you can't. So for example, the 994 cognitive assessment and functional assessment code is considered, chronic care management is considered. So there are a few codes that you can't, but let's say somebody needs to have an urgent visit for something, because they may even be having crisis. You can bill for those kinds of things. So in most of the EM codes, and one thing I'd like to refer people to is the RFA, which is very specific. And if you just type in guide model, CMS guide model into Google, you can find this, or I can send it to people to distribute.
Awesome. Another question here is from Lisa Rund, and the question is there any plan for including the National Task Group on Dementia in IDD, Intellectual and Developmental Disabilities, which is a nonprofit organization made up of professionals who were part of this work, a lot of acronyms there. The focus is on providing training and information to those of us who work with people with intellectual and developmental disabilities. These disabilities have a great effect on the presentation of dementia in individuals, and it can be a real challenge. So any discussion around the overlap between individuals with intellectual and developmental disabilities and dementia in this project?
So I think this is an important question. It's important for the specific question, but it's also important for the concept. So I have to tell you that Medicare is allowing a lot of discretion to the individual participants. So for example, how they decide to do the caregiver training, how they do the training of the care navigators is going to be determined by the participants, which are the sites that adopt these, not be mandated by Medicare.
Okay.
So if there are these good programs, yeah, please get in touch with your nearest guide participant.
Awesome, great. Another question is, who qualifies for the initial home visit? Does it need to be done by an RN or an MD, or can it be the dementia care navigator?
The initial home visit, first of all, the beneficiaries are people who have moderate or severe dementia, and there are all sorts of criteria for that, but it can be any member of the team. And it turns out there are specific elements that have to be conducted at that in-person visit. That was the topic of last hour's call, but we're planning on sharing it between the dementia care specialists, the dementia care assistant, and a social worker. The current requirements are that it has to be done once within 60 days of enrollment, but there is not an ongoing requirement for additional in-person visits.
Awesome. Okay, thank you. Question from Catherine Stambaugh. Are any FQHCs applying, or are they excluded from this?
They are excluded because they're not Medicare B providers. However, there's been a lot of interest in FQHCs applying as partner organizations. So they could actually provide services, but they would have to partner with a Part B provider who would be the guide participant, and then the guide participant can transfer money to the QHC.
I'm just going to add on a little bit more to that. When talking with CMS, they do want to find a path for FQHCs to participate. So again, as Dr. Reuben said, if a physician who works at an FQHC or who is affiliated, a leader there, they can submit the application. And I really would encourage, let's push the envelope here with CMS. Let's try to make it work. So please encourage you all to submit applications.
Nice.
And show CMS what strong partnerships and packages we can put together from California.
That's fantastic. One question is about why Medicare Advantage is excluded. So why no Medicare Advantage in this? It's really limited to the fee-for-service. So Anastasia, you want to share that?
Yeah, that's a great question, because basically CMS has said that Medicare Advantage plans can already provide funding to providers for this type of team-based approach. So one thing we're looking at is, how can we put something stronger in writing to our health plans in California? How can we raise this up so that because Medicare Advantage plans in California and other states, they can do this right now. They can package these services, make this payment model. So I think we should all be asking them to do this.
Okay. Great.
Amen.
There you go. Let's see. One of the questions is pretty specific. If you're applying to the new program track and the practice has only a dementia care qualified clinician, but no health navigator, so they're lacking the navigator role, can they still apply?
They can apply, but they can't implement the model.
Yeah, it's a requirement.
It's a requirement.
Yeah.
Yeah, there are two requirements in terms of providers. You have to have a dementia care navigator, and you have to have a clinician with dementia proficiency. So it's probably
no getting
not
around that.
It's probably not worth the effort.
Yeah, right. Another question from Dirk: how do you demonstrate monthly engagement in the model for the purposes of payment?
Oh, I love this question because it's a question that I corresponded with CMMI this week on. I asked them specifically, and it's interesting because this is new ground for Medicare. They will have, whether the participants continuing to be enrolled, you'll have to report that, but there is no specific service that has to be reported each month. They will have to support a G code and a diagnosis code, but not a specific service. So for example, let's say somebody who has mild dementia and there's a requirement that they have contact with the program every 3 months. During those other 2 months, they might be participating in support groups, the community-based organization. They might be getting some additional caregiver training, but it's not a billable service. So you would just bill that the person is in the program with a G code.
Wow.
That was really good news. That was really good news.
Awesome. Great. A few questions about how to connect with UCLA and your team, David. What's your suggestion? You mentioned that you have a particular office hours, essentially.
Yeah, the office hours are generally on Tuesdays, but I can't tell you what time it is. I will. How about if I put a contact person in the chat?
You can do that. I also wanted to share something, and again, it was wonderful to see the ADC model. As Dr. Reuben shared, there are different models. You have choices if you're looking at this. There are multiple community-based organizations. I know the Alzheimer's Association is also partnering with different groups. So on the Dementia Care Aware website, we're also providing resources. And Anastasia, if you have thoughts on this as well, we want to make sure you're able to see where can you partner up, where can you get help. And so please feel free to reach out and go to Dementia Care Aware, and there is a landing page for more information about guide. Anastasia, were there some other resources you wanted to suggest?
So on that landing page about guide on the Dementia Care Aware page, so this is California specific lists of CBOs, and you can email the Dementia Care Aware team to get more lists, improved lists on there. But we at DHCS, we are reaching out to provider associations. And I would suggest also, if you're in a particular county, what have you, perhaps their local medical association, or if you know a particular IPA or physician group, knock on their door. I mean, there's not a good central matchmaker website per se. The other question I saw was, how will we know which organizations were successful in guide? And we will certainly, CMS will post that, and we can echo that. But for right now, the matchmaking, looking at the application process, it's a little bit messy, but we think you at the local level probably know best which doors you should knock on.
Awesome. That sounds wonderful. I think we have time maybe for one more question, and then we need to close out with how to claim your continuing medical education. So one of the questions was, what are the qualification requirements for a dementia care navigator? David, do you want to tackle that one?
So they were very broad. I think a number of these are going to be community health workers. Some models use community health workers, ranging from at kind of at the lowest to the highest being the advanced practice practitioners, nurse practitioners, et cetera. But they do not specify. They specify the roles and responsibilities and training, but they don't specify the actual type of staff and professionals.
Okay, all right. So room for interpretation maybe a little bit there with some of that. So let me just share for one moment. I want to close us out with the detail. You can receive CME credits for various individuals, as you can see, AAFP, and then also ABIM, MOC, and for therapists, CAMFT credit. So once you do the survey, then you'll be able to get the QR code and claim your credit. So take advantage of this. I'm going to stop sharing, but most of all, I want to thank our panelists today. Thank you for sharing some ideas on how to dig through this, almost 80-page RFA. And thank you, Anastasia, for Department of Healthcare Services putting this webinar on and really helping California step up and have hopefully a lot of high quality, very competitive applications. And thank you, Molly, for the wonderful work that you're doing with caregivers and families. Wonderful to have so many great groups here. And thank you, everybody, for joining us.